A very good morning to all of you. Welcome, ladies and gentlemen, to the second day of Infectious Diseases Conference 2025, organized by the Infectious Diseases Forum of the Ceylon College of Physicians in collaboration with the International Society for Infectious Diseases and Clinical Infectious Diseases Society of India. So before we dive into today's proceedings, here are a few housekeeping notes. Please silence your mobile devices. The book of proceedings containing the program can be accessed by scanning the QR code, which is available over at the registration desk. And this is a kind reminder to please visit the stalls of our industry partners in the venue. We hope you would stay with us until the end of the conference, where you will be able to win cash prizes from the infectious diseases quiz. Our quiz masters are ready to give you a good challenge. So as we have all gathered here today for the purpose of exploring into the infectious diseases that are common, prevalent, and emerging in Sri Lanka, let us, without further ado, move into today's proceedings. The first session of the day is regarding fungal infections. The symposium will be chaired by Dr. Primali Jayasekara, consultant mycologist at Medical Research Institute Sri Lanka, and Dr. Asanka Ratnayaka, consultant physician at Colombo South Teaching Hospital. I cordially invite Dr. Jayasekara and Dr. Ratnayaka onto the stage.
Good morning, ladies and gentlemen. So, Dr. Jayasekara is on her way, so she'll be here in a short time. I'm going to start the fungal infections, the challenging cases, critical decisions session, and the first lecture will be delivered online by Dr. Marisa Miseli. So, she's a distinguished expert in the field of infectious diseases, currently serving as a medical doctor with the notable qualifications including MD, FIDSA, FACP, and FECMM. Her expertise is further established through her role in Professor of Medicine in the Transplant Infectious Disease Program, Division of Infectious Disease, Department of Internal Medicine at the University of Michigan, Ann Arbor, Michigan, USA. So I would like to hand over to Dr. Marisa Miseli to start the presentation.
Wonderful. Hi. Thank you so much for the kind introduction, and thank you for inviting me to give this presentation. Unfortunately, I cannot be there, but I stayed up late to be able to give you the presentation live. And I hope sometime I can go visit your beautiful country. My disclosures are presented here in the slides. I'm a consultant for Synaxis, and I'm a primary principal investigator in several clinical trials dealing with antifungals, but we're not going to talk about any of those in the present talk. So before we start, I would like to kind of give a review of the clinical relevant molds, and mainly to focus on the morphology. So I wanted to kind of go back a little bit on the basics and talk about, make a big distinction in molds and yeast. Yeast are small cells that divide by budding. We know Candida species, we know Cryptococcus species, Rhodothorula is another emerging yeast infection. And then we know the molds. The molds are filamentous, and they have conidia and spores, and they reproduce and transmit, and the transmission is through spread of the spores. So the most common ones and the ones that we're going to talk about today are Aspergillus and Mucor. So these two. So So basically, as a reminder, these two molds, the Aspergillus species and the mucoralis, are highly molds, meaning that they are transparent. And the big difference between the two is that Aspergillus is a septate mole and Mucoralis is not septated. Like here, you can see how Aspergillus has these tabications of septate. And then the other thing is that it branches, right, in acute angle, while mucoralis or mucor is a more like a ribbon shape, more irregular, and when it branches, it does it more in a more irregular fashion, and definitely does not septate. So these are going to be important features when talking about these two fungi, because it's going to be important when you talk to the lab to say, okay, what are you seeing in the microscope? Do you see in the lab, they are able to identify these two molds based on the shape of the spores or conidia. And then they're going to be able to tell you if they are septates or they are not, and they're going to tell you if they branch or not in the pathology and in the stain. So here is again mucor, this is Aspergillus, and also you can ask your laboratory, the microbiologist, to say, okay, what is the colony like? So by the colony, they can also tell you, does this look more like Aspergillus or this is look more like mucormycosis? And we're gonna see, down the road how this is very important when we need to start any treatment. So let's talk about who is at risk of these infections. Why these patients get this type of infections? These infections are not very common, but in the immunocompromised host, they are common in a way. So, and the risk of this infection, the invasive fungal infections, is given by the cumulative state of immunosuppression of the patient and the environmental exposure. So these molds are in the environment. You can see it in the hospital. You can see it in construction. You can see it in moldy bathrooms or walls. Patients that are do gardening or farming are exposed to those. Also, after natural disasters, motor vehicle accidents, and even war wounds, injuries can cause direct inoculation of these molds because they are in the environment. So the host is also very important. What is the risk of the host? So the absence of neutrophils, abnormal phagocyte function, impaired cell-mediated immunity, or impaired mucosal immunity, right? So patients that are going to be at risk for mold infections are going to be those who have a recent history of prolonged neutropenia, those who have received a stem cell transplant, patients that have hematological malignancies that are undergoing high-dose chemotherapy, prolonged use of high-dose steroids, T-cell immunosuppression or TC depletion, patients who have inherited severe immunodeficiency, those who are receiving small molecule kinase inhibitors like Jakafi, and patients who are in the ICU. And why is important to make a diagnosis of these infections? Why is important to recognize, to know who is at risk and what are the exposures that put these patients at a higher risk? Well, these infections are associated to a very high mortality. Making an early diagnosis and acting on it, start managing those patients with antifungals, it actually improves survival from reduced actually mortality by 60%, making a prompt diagnosis like within 10 days of presentation. So it's really, really important. So in the last few years, there have been many efforts to develop strategies for early diagnosis that we know lead to improvement. I know that Dr. Chandra is going to talk to you next about diagnosis, and I'm sure he's going to emphasize this point as well. So, and that's why I'm not going to, talk much about diagnosis during this talk. But let's start with the case, a 29-year-old female that got a liver transplant after having a liver failure due to acetaminophen toxicity. She also has MS, and after transplant, she develops headaches and altered mental status. This happened within a month after transplant, and that's quite unusual. Initially, it was thought that it was related to worsening of her multiple sclerosis. But then when we did a CAT scan, an MRI of the brain, we saw that she did have these lesions in this massive edema. So actually, we were able to do a biopsy, and biopsy showed these forms, these fungal forms that were consistent with Aspergillus, as we mentioned before. So this is why it's so important to recognize, to know what is the morphology that we expect, when we're presented with molds, right? So she actually eventually also grew Aspergillus fumigatus, and she has a happy ending. She actually did very well after many months of therapy with voriconazole. So let's talk about invasive aspergillosis then. So it's the most frequent invasive fungal infection, actually. And as we mentioned, the host is the severely immunocompromised patients are at higher risk. And among these, actually prolonged neutropenia, high-dose steroids, and those receiving chemotherapy, specific chemotherapies, are at higher risk. These patients typically are going to be receiving prophylaxis nowadays with either fluconazole or a kind of candine, depending on the malignancy that they have, the chemo they are getting. And it's not uncommon to see a breakthrough invasive aspergillosis, basically because fluconazole doesn't cover molds, and echinocandins actually they're used in a reduced dose, like 50 milligrams instead of 10, and there may breakthroughs may occur. Also, some of these patients also receive voriconazole or posaconazole or isavuconazole, which are antifungal therapies that actually typically cover for aspergillus, but there is more, now there is an increased emergency of azole-resistant aspergillus. So when you you can also have breakthrough infections despite being on appropriate prophylaxis because of development of resistance. So as we mentioned, these molds, Aspergillus, is ubiquitous in air, water, and decomposing materials. So of all the Aspergillus species, there are many species. Aspergillus fumigatus is the more frequent one. So we inhale the conidia, and the mole gains access to the lungs, and the macrophages are not well functioning. The phagocytosis is impaired, so then angioinvasion occur, and this is how the mole causes infection. So it's not uncommon to see pulmonary infarction in patients with pulmonary aspergillosis. So let's present a second case, 25-year-old man that was hospitalized after being treated for acute myelocytic leukemia. He gets chemotherapy, goes into complete remission. 3 months later, he relapses and then again gets induction chemotherapy and is neutropenic for about a month. So they do an X-ray. They has nodular lesions in both lungs. They do blood cultures. They are negative, but they do a bronchoalveolar lavage, and actually they said septate branching hyphae that you can see here, consistent with Aspergillus fumigatus. So then, as they do a CAT scan of the chest, right, and they actually see that there are nodules with this haziness, which is called halo sign, and then eventually. Down the road, when he gains neutrophils, then that nodule starts to cavitate and shows this area that is called the crescent sign. So as I mentioned, these are two radiological features of pulmonary aspergillosis. So we have the haziness, that the halo sign actually is hemorrhage happening there. And when we see that the halo sign is actually that the nodule is necrotizing inside, so it's kind of shrinking, and then this is air that we see due to ongoing necrosis. So the X-ray sometimes is useful, most of the time is not. So even in a patient like this, when you have suspects that the patient is at risk for aspergillosis, even with a normal X-ray, you always want to do a CAT scan, right? And typically we do a high resolution CT chest that is able to even see teeny tiny nodules. So how do we treat? I just put here in the on the right in the slides just a reminder of what the antifungal classes are and how they work. But just to cut to the chest, we treat invasive aspergillosis with voriconazole, which is the drug of choice. The second line, or even is also approved for treatment of invasive aspergillosis, is isavuconazole. And then, of course, we also can use posaconazole, but voriconazole and isavuconazole are the two first-line drugs recommended nowadays. So they are very active against Aspergillus fumigatus unless develops resistance. Basically, when you start these patients on voriconazole, you need to be aware of toxicities, mainly hallucinations, could be liver toxicities, and then QTC prolongation and tons of drug-drug interactions. Isavuconazole is broad spectrum activity, has broad spectrum activity as well, and in addition to covering for Aspergillus, covers for mucorales, which voriconazole does not. So that's an important difference. And also the safety profile is much broader. There is less drug-drug interactions, and also regarding the QTC, actually shortens the QTC. So if you have a patient that has prolonged QTC, you can put them on isavuconazole. It's safer. So then we have Ambisome. We use Ambisome for aspergillosis when we cannot use Vori or Isa or Posa. Echinocandins like aspofangin, migafangin, anilodufangin, or resafangin are like a last resort and typically are used for salvage. Now, moving on into mucormycosis, similar to aspergillosis, it's very important to talk about this infection because of even there is this rare infection, it's associated to a high mortality. Patients have limited treatment options, and it's important to be able to distinguish aspergillosis from mucormycosis. And so that's why I want to emphasize this, how important the morphology is and how the management is slightly different. So the most frequent species that we see of causing mucormycosis are Rhizopus, mucor, and rhizomucor. Basically, is exposure to the environment, again, soil, the kind of matter, compost, and foods can have, we can find mucorales there. The high groups at risk, the high risk groups we already mentioned. This also can occur in poorly controlled diabetes, in addition to patients with prolonged neutropenia, hematological malignancy, stem cell transplant, and solid organ transplant. So, and you know very well that this has been also seen during the COVID pandemic, that has been an increase on mucor and aspergillosis coexisting with COVID-19. So, let me skip into that. So the pathogenesis, this mold is able to evade the immune system of the patient, which is already weakened. Patients who have abnormal macrophage function, like patients on steroids, or patients with hyperglycemia or DKA, or patients with iron overload, and also the ability to have enhanced virulence secondary to symbiotic bacteria, relationships with the mold, and also patients apparently with exposure to antifungal agents like voriconazole had an increased risk for mucorales. And needless to say that also mucorales can occur as a breakthrough infections in patients that are getting other antifungals. So the clinical presentation is could affect the sinus and the orbits and the brain. You can have pulmonary mucormycosis, cutaneous mycosis, and other forms. The diagnosis is with pathology. You need tissue diagnosis to be able to diagnose mucormycosis, and this is why, again, it's very important to know the morphologies. So going back to this, the diagnosis is challenging because sometimes most of these patients, let's say, are very sick, they are thrombocytopenic, you cannot do a biopsy, or the location of the lesions are not accessible. So let's talk about two cases. One case is a 23-year-old male with lymphoma that received chemotherapy, had a short neutropenia, 3 days only, but then comes back with this lesion. The lesion had was suspected to be a cellulitis. He, however, got broad-spectrum antibiotics, but then evolved into these necrotic lesions that were biopsied and actually showed these hyphae that were consistent with mucor, and eventually he also grew mucor in cultures. So he also is a very successful story. The radiological doing radiology is also important, particularly when you are suspecting sinus and brain infection, but also in the chest. One of the important signs of mucor in the lungs is the reverse halo sign. Remember how before it was the nodule and then the peripheral haziness? Here is the thicken of the surrounding the haziness. So mainly this is related to hemorrhage in the center and necrosis in the periphery. So then another point, I know I'm over time, but a couple of things I want to clarify here is in the management of mucorales or mucormycosis, surgical debridement is paramount. So these patients need aggressive debridement to clear margins, and many times they need to be taken to the OR more than one time. So in the case of the patient I mentioned before, you can see that he achieved very nice clear margins and then eventually was able to receive a graft and he's alive. So similarly, just to finish, this is a patient that is a liver transplant that in days went from this wounds closing by second intention, but to this area of necrosis. And he went to surgery and they were unable, the necrosis was so massive that they were unable to debride everything, and eventually he died. So treatment is combined with first line of therapy is with amphotericin B. We use liposomal amphotericin B, and again surgical debridement. Prognosis is very bad, but patients may survive. And what makes it worse is when the underlying condition cannot be reversed. So to conclude, so basically my take-home message for you is to be able that with this talk you be able to understand that morphologically aspergillus and mucorales are different, that the morphological differences are important when dealing with these patients and when needing to make decisions, particularly in patients with mucorales, because you need to take them to the OR right away. And also remember that have to have this diagnosis in mind to be able to suspect them and to act quickly to improve the survival of these patients. Thank you.
Yeah. Thank you, Dr. Maria Amseli, for that very interesting lecture on invasive fungal infections in immunocompromised. So we are actually a bit short of time, so I can allow one question if there's any.
Marisa, good to see you. Ramesh, can you briefly, quickly tell the audience about how would you use biomarkers in the diagnostic methodology that you practice?
Okay. Yes. Hi, Ramesh. And I see Dr. Chandra too. Hi. So I know that Dr. Chandra is going to talk about biomarkers. So when talking about aspergillus and mucorales, the biomarkers that we really have available today are more directed towards the early diagnosis of aspergillosis. Basically, so we use, we don't do screening with serum galactomannan, but we use it for diagnosis of aspergillosis in patients with, at risk with clinical and radiological suspicion. So we do BAL in galactomannan in the BAL, and we do galactomannan in serum. And we also use fungital, but, we take it with a grain of salt because it may not be, is non-specific. So many times it's elevated just because the patient had surgery.
Thank you very much, Dr. Miseli.
I beg your pardon, Dr. Ratnayaka, and my apologies to all for interrupting the session. I'd like to invite the co-chairperson of the session, Dr. Primali Jayasekara, consultant mycologist at Medical Research Institute, Sri Lanka, to join the symposium. Thank you.
Now, our next speaker is Professor P.H. Chandrasekhar from USA. Professor P.H. Chandrasekhar was born and raised in Sri Lanka, has served as a professor of medicine and infectious diseases for over 40 years at Wayne State University, Detroit, Michigan. He served as chair of the Department of Infectious Diseases and program director of the Infectious Diseases Fellowship Program. He is a fellow of the American College of Physicians and fellow of Infectious Diseases Society of America. He served as the president of Michigan Infectious Diseases Society during 21 to 23. His main interests include infections among immunocompromised hosts, particularly those with cancer and those underlying hematopoietic stem cell transplantation. After recent retirement, Dr. Chandrasekhar is involved with medical education globally in the field of infectious diseases. Dr. Chandrasekhar is promoting awareness of infection, particularly in countries where the field of infectious diseases is not identified as a subspecialty of medical practice. Over to you, Prof. Chandrasekhar.
Thank you. Thanks for the kind introduction. Since time is limited, I'll get started right away. Thank you for giving me this opportunity. And once again, my best wishes and congratulations to the forum for putting up this international meeting. The topic that I was asked to speak this morning is about the diagnostic approach of invasive fungal infection. You heard Dr. Miseli talk about the two common fungi that produce invasive infections. So most of my talk is going to revolve around that. However, I just want to point out, we're going to be talking about invasive fungal infection. We are not talking about toenail infection, which may be caused by superficial fungi or dermatophytes. Okay, these are systemic fungal diseases, and that has a major morbidity and mortality in many populations, particularly the compromised hosts. So we're going to be talking primarily about the organisms that cause systemic fungal disease. And what are they? They're listed on the slide. As you can see, World Health Organization has categorized into critical group, high group, and medium group based upon the priority. And the priority is based upon the incidence, antifungal resistance, and the high mortality associated. And as you can see, drug resistance is increasing, as Dr. Miseli mentioned. There is environmental, agricultural pesticides containing antifungals. As a result, fungi become innately resistant to many of the azole drugs that are commonly used as agricultural pesticides. And there are no vaccines available. And as you can see in the critical group, there is Cryptococcus candida aspergillus. These are three common fungi that produce major systemic fungal disease. And then the others are classified into the high group and then the medium importance group. Okay, now all these fungal diseases are very difficult to diagnose. Why is it very difficult to diagnose? Because it occurs commonly in very sick people. And therefore, you can't do invasive procedures like biopsy. They may be thrombocytopenic. They may be in the ICU. They don't produce a good inflammatory response. And therefore, there won't be any typical features of inflammation for ready diagnosis. They're very non-specific signs and symptoms. And serologically, they are so immune compromised, they may fail to produce antibodies, so serological tests may not be useful for diagnosis. Histology, there are 20 different organisms that look like Aspergillus. So it's very difficult because of the close similarity. And cultures are highly undependable because the organisms grow slowly. Many times the fungal cultures are negative. So the sensitivity from culture detection is pretty low. So for these variety of reasons, diagnosis of a fungal disease, systemic fungal disease, is very difficult. So we're going to talk primarily about Candida and Aspergillus, okay? First few slides. And then we'll talk about the diagnostic summaries and the newer tests that are coming along. Candida, we all recognize what kind of host is susceptible to, is listed on the left-hand slide. Older patients, neutropenic patients, renal failure, burn, traumas, all of us know what kind of patients are at risk. A lot of them are in-house patients in the ICU with invasive devices. And the interventions that are listed on the right-hand side can predispose these patients very easily to systemic candidiasis. And the way we diagnose is primarily through blood culture, if we are lucky enough to capture it in the blood. In systemic fungal disease, there may be about 40% chance you may pick it up in the blood culture. For the majority of times, your blood cultures may be very negative, so it may be an insensitive marker. The biomarkers that was mentioned is serum beta-D-glucan, is a common fungal constituent in many of the fungi, exception being mucor and cryptococcus. So this has an excellent negative predictive value. If it is absent, it is highly unlikely we are dealing with a fungal disease like candidiasis. So we depend on biopsy, and biopsies, as I mentioned, are not always easily doable. The newer methods are MALDI-TOF method, as you can see, is a spectrometric method, and the other is the magnetic resonance. So we'll talk about the beta-D-glucan and the magnetic resonance assay, which are as relatively recent tests. So beta-D-glucan is a presence of a fungal constituent that could be in the serum in patients who have fungal disease. So more than its presence, its absence is more useful in excluding diseases like candidiasis. And as I mentioned, apart from cryptococcus and mucor, this particular polysaccharide is present in most of the other fungi. However, there could be false positives, and the false positives such as dialysis filters, IVIG, and albumin are very important to consider in the clinical situation. There's limited data in solid organ transplant patients. However, this has become widely available in the United States in many of the centers, but the turnaround time may be a little bit delayed. Again, we use it primarily to exclude invasive candidiasis in systemic candidiasis. What about the magnetic resonance assay? As you can see, it's a quantitative molecular diagnostic method. Currently, the method is useful for diagnosis of 5 different species of Candida. In an increased prevalence setting, because of its high sensitivity, it is a very useful marker. However, in a low prevalence setting, because of the high sensitivity, there could be false positives. So clinical interpretation may be warranted. More than anything else, this particular quantitative molecular method, the tool instrument that is required is very expensive, and most of the institutions have been hesitant to buy the equipment. So, and therefore it hasn't caught on very widely around the country in the United States. However, it's a very sensitive tool for detection of invasive Candida in the serum. And deep-seated candidiasis, again, the diagnosis may be questionable in the absence of candidemia. Now, let's move on to Aspergillus, okay? Candida is very common. Next organism is Aspergillus. How do we make a diagnosis? Dr. Miseli already mentioned the importance of plain X-ray and the importance of high-resolution CT. It's very important. And the other tools that we have currently available among the biomarkers, it's serum galactomannan or the BAL galactomannan. Some people would even use it in sterile fluids such as CSF or pleural fluid. PCR is another tool that has become increasingly commonly available as far as you have a standardized test, both in the blood as well as in the BAL. Radiology, as Dr. Miseli already showed, halo sign and air crescent sign are pretty diagnostic, suggestive of aspergillus. A halo sign occurs early, whereas with return of neutrophils, the air crescent sign with the air trapping begins to appear, particularly as the neutrophils start returning after chemotherapy. So these radiological findings are very important, and as she made a point, chest x-rays may not be as sensitive, as reliable. So a negative chest x-ray does not exclude aspergillosis, whereas a CT is a very good tool. So today, I don't rely on chest x-ray. I routinely order CT scan, high resolution, in order to pick up those subtle findings early on in the phase of the disease. Galactomannan is again a fungal constituent, fairly specific for aspergillus, but you can see other fungi, such as Histoplasma, Cryptococcus, can also produce a false positive galactomannan. So one needs to be very careful. Clinical interpretation at the bedside becomes important. And as you can see, there are other things that can make a falsely positive galactomannan or a falsely negative galactomannan if the patient is on antifungal prophylaxis or if the disease is focal and not systemic. For example, Aspergillus sinusitis, you look for the galactomannan in the serum, it may be negative. Okay, so these kinds of false positives and false negatives should be kept in mind. Now, this is a slide that tells us what specimens do we use and how do we subject the specimens to a variety of different tests. As you can see here, if it is the tissue, we do culture, histopath, and PCR. If it is blood, we can do microscopy, culture, PCR, biomarkers, beta-D-glucan galactomannan, histoplasma cryptococcus antigen, serology, and metagenomics. We'll get to that in a second. CSF, again, like that, each of the specimens can be subjected to a variety of different tests in order to detect invasive fungus. So this figure nicely demonstrates that. Now, as you can see, a timeline. We began in the 1900s. Histopathology came out in the 50s. And then in the 80s, the galactomannan assay and the beta-D-glucan assay came out. And more recently, now we have the magnetic resonance and the histoplasma lateral flow assay, and most recently, metagenomics or next generation sequencing. We'll get to that after these next two slides. So as a summary, as you can see here, Candida, we would use serum beta-D-glucan. This slide and the next slide talks about different organisms and what kind of specific tests we would recommend for each of these. For Candida, it would be beta-D-glucan, MALDI-TOF, and magnetic resonance. For Cryptococcus, you could do a cryptococcal antigen with high sensitivity and specificity, both in the serum as well as in the CSF. For Aspergillus, it would be galactomannan antigen and PCR, and this could be performed in the serum, BAL, or CSF. Once again, false positives have to be kept in mind. For Mucor, there are no rapid antigen or PCR. Unfortunately, we still rely on morphological appearance and culture, and these are costly. For pneumocystis, we can do serum beta-D-glucan. There is no culture, immunofluorescence assay in the BAL fluid, and in the tissue morphology or PCR in the BAL fluid are useful tools for diagnosis of pneumocystis. For endemic fungi, you could use antigen in the urine or serum, antibody test, or if you have available to have tissue, you can do tissue morphology. So this kind of summarizes how do we look for the different pathogens, what kind of tests we apply. The tests of promise include PET-CT, PCR, and metagenomic sequencing. I'll make a couple of comments about each of these. PET-CT Not only does it locate anatomically, it also gives us a functional idea as to where the problem might be. Also, PET-CT can tell us sequentially, when we do PET-CT, the prognosis of the patient. If the glucose uptake is minimal or it starts diminishing, we know there is decreased metabolic activity at the site of the infection, and therefore the patient is getting better. That would be the inference. So PET-CT not only helps us to localize the site of infection, but also prognosticates regarding the outcome of the infection. But the limitation is fairly nonspecific. It can be happening in cancer, or it could be happening in any other infection, which could be fungal or bacterial. So it may fail to distinguish what pathogen we're talking about. Okay? And so those would be the downside of the PET-CT. This is the microbial cell-free DNA. And through this PCR method, as you can see, we can detect bacteria, viruses, fungi, and parasites. So we need to have a database of all these organisms with their genetic sequences. And we can take the patient's blood and look for even minute quantities of the microbial DNA. And this would help us to make finding needle in a haystack. So this has become increasingly popular for us to do this microbial cell-free DNA PCR method, primarily in blood and in patients in whom we are unable to make a diagnosis. Not infrequently in the US, this method is being increasingly applied. So this kind of tells us the metagenomic next-gen sequencing, cell-free DNA PCR, are the two most commonly employed new tests. The metagenomic next-gen sequencing essentially looks for any non-mammalian DNA through next-gen sequencing to detect the presence. And this would not be a PCR method. This would be a sequencing method by which we identify the presence of non-mammalian DNA material. This is also very sensitive and has become fairly popular today for the diagnosis of invasive fungal disease, both cell-free DNA PCR and the next-gen sequencing. Needless to say, these are expensive, not readily available, and obviously we need to make it much less expensive methods. The others listed here are fairly new. They are not available for prime time as yet. The volatile organic compounds detectable in the breath because of the metabolic activity of the fungus in the lung. Microfluidics-based diagnostics is for point of care, and the development has not occurred very well with this particular methodology, and the other two are also in development. So today, if I were to list the two new methods, they are listed right on top: the metagenomic next-gen sequencing and the cell-free DNA PCR. So in summary, currently we do not have tests that have high sensitivity and specificity. The turnaround time is pretty long. Access to many of the fungal labs is very limited, even in a highly developed country like the United States. Not all the hospitals can afford to have very sensitive molecular assays. As a consequence, we end up using a lot of empiric antifungals with very poor stewardship. So what do we need? We need molecular tests. But these molecular tests are costly, and they rely on adequate sampling. And sampling is a major problem. We may not get enough sample or a good sample. And the tests require standardization and maintenance, and contamination risk with this method is always of concern, particularly with the PCR. So in summary, invasive fungal infections occur annually around the world. Sri Lanka is no exception. The diagnosis remains very challenging, unlike bacterial infections, for the reasons that I have already outlined. The tools available to us for diagnostics are very limited. We still depend upon weights of evidence. What does that mean? We look at the clinical parameters, we look at the epidemiological clues, We put together the laboratory test, whatever we have available. Based upon the weights of these evidence, we conclude that the presence of presence of fungal disease is highly likely, and then embark on treatment. What we need, low-cost test, easy-to-use test, highly sensitive specific molecular assays that are readily available at the bedside as point-of-care tests, and to be able to differentiate colonization versus infection. I didn't mention this all this time, but presence of organisms simply does not always mean infection. Aspergillus in the sputum is a typical example. You need to look at the clinical interpretation, which whether it is significant or not significant. So the PCR may detect the organism, but it won't tell us the significance of the presence of the organism. That again is up to clinical interpretation. We overall need increased awareness of invasive fungal infection among physicians and in particular among the public. I don't think the public knows enough about the presence of invasive fungal diseases, their importance, particularly in immunocompromised patients. That awareness needs to be increased, but as a first step, we as physicians, we as infectious disease doctors, as clinical microbiologists, public health personnel, need to improve our working knowledge of invasive fungal disease in order to provide optimal care to our patients. I think with that, I'll stop. Thank you very much for your attention.
Thank you very much, Dr. Chandrasekhar, for that very detailed presentation on the approach to diagnosis of invasive fungal diseases. We have some time for a couple of questions.
How do you utilize, is there some standardization for quantitative PCR at this point of time, particularly in a BAL setting? Or how are you, before you retired, how did things change in Wayne State?
Well, the quantitative PCR has not become mainstream in the US. It is not widely available, and it can be done upon request. Once again, the interpretation of the quantitative PCR is a challenge. What level should I consider as important? Should there be 1,000 copies? Should there be 500 copies? So that kind of understanding is not standardized. And until that becomes available, the significance of the quantitation remains a challenge at this time. This is very useful in the setting of pneumocystis. Pneumocystis PCR may be positive if it is a highly sensitive PCR test. And very often we are challenged with the significance of the presence. Is it colonization? Is it contamination? Or is it a true infection? So at what level should there be a number that I should really consider as a true infection? That has not been worked out for any of the organisms at this time. But clearly, there are tools that are available, and the lab will give us the answer if we ask them to. However, the interpretation is left up to the clinician at this time.
Can I ask a question, Professor Chandrasekhar? I am Dr. Primari Jayasekara, consultant mycologist from MRI. Now, we don't have beta-D-glucan test in Sri Lanka. So, if Candida blood culture is negative, what is your experience doing Candida Manan antigen and anti-Manan antibody in a patient that we suspect of having invasive candidiasis? We do have both Candida Manan antigen and antibodies.
Yeah, that's a very good question. If you look at the new guidelines, the Manan antibodies or antigen is hardly even mentioned for a reliable diagnosis of candidiasis. Today, the Manan antibodies are very non-specific. It would not tell us the presence of acute infection. Manan antigen may have a lower sensitivity If it is present, it may be useful. An absence of it does not exclude systemic candidiasis. So as I mentioned today, mannan antigen and mannan antibodies are not high reliable lab markers for diagnosis of systemic candidiasis. Your point is well taken. Blood cultures may not be positive in a high number of patients. It may be positive, let's say 30 to 50% of the times. The other half of the times, you suspect systemic candidiasis. You have no easy way to exclude it. If the beta-D-glucan is available and if it is negative, that can safely exclude it, systemic fungal disease. But if the beta-D-glucan is not available in your country, then it becomes a problem. I can tell you many of the institutions, at my institution here, we do not have beta-D-glucan. We have to send it out. That means the turnaround time is at least 2 to 3 days before I get the answer back. During that period, if the patient is critically ill, I have to use the drug empirically, use an anti-candida drug until I get the answer back. So very often I have to use empiric anti-candida drug while I am waiting for the serum beta-glucan to come back. So
Recording
what
stopped.
I'm trying to say is at this time, it is a clinical judgment call as to when you can strongly suspect candidal disease in a given patient. We do not have a very reliable, easily doable bedside or point of care diagnostic test.
Yeah, so in the interest of time, I would like to conclude the first part of the symposium on fungal infection while thanking Professor Chandrasekhar again. Yeah, thank you.
Thank you.
So we'll move on to the next part, which is going to be a case-based discussion, and it will be moderated by Dr. Ranga Gunasekara, who is a consultant physician and is a elected council member of the Sri Lanka College of Internal Medicine. He has a lot of experience working in the both Sri Lankan public health system, and he's holding roles at Nuwara District General Hospital. He's the Hill Country Clinical Society, and he has also held a position at the Norwich University Hospital NH Foundation Trust. So I will hand over the proceedings to Dr. Ranga Gunasekara to continue.
Good morning, everybody. Let me start the symposium on case-based discussion on mycology. Let me invite both our resource persons, Dr. Mayur Ramesh. Dr. Mayur Ramesh is a consultant in infectious diseases and an academic researcher from Henry Ford Health System. Dr. Ramesh specialized in infections in solid organ transplant, and he has contributed to research in many topics related to transplant infections. He has an H-index of 32 with more than 8,000 citations. May I cordially invite Dr. Mayur Ramesh. And our next resource person is Dr. Namal Jayawardena. Dr. Namal Jayawardena is currently attached to the National Cancer Institute, Maharagama, as the consultant mycologist. She obtained MBBS in University of Sri Jayawardenepura in 2007, postgraduate diploma in medical microbiology 2013, and MD in medical microbiology in 2016. She is involved in diagnosis and treatment of invasive fungal infection in the immunocompromised patients at NCIM. She has 37 publications to the date. Let me cordially invite Dr. Namal Jayawardena. For our case presentations, let me invite Dr. Chetana Premasiri, Senior Registrar in Mycology, Apeksha Hospital, Maharagama. Over to you, Chaitra.
Good morning, and thank you very much, the organizing committee, for this opportunity. And without further delay, let's get straight to our case presentation. Right. So we have two cases lined up for this session. I'll start with the case number 1. So we have a young lady who is 33 years old, and she is a mother of 2 young children. So she was diagnosed with relapsed primary mediastinal B-cell lymphoma in February 2023. So for that, she has completed 6 cycles of chemotherapy and remained asymptomatic until the point of discussion in our history. In last February, she was readmitted to hospital with dysphagia or dynophagia to both solids and liquids. But she did not have fever, and also there were no urinary, abdominal, or respiratory symptoms. She also did not complain of chronic cough, wheeze, or hemoptysis, and there was no recent onset cachexia. So this is the chest X-ray taken on the day of admission. Dr. Anga?
Yeah, let me interrupt you there. Dr. Ramesh, what's your take on the chest X-ray of this patient?
At this time, the patient does not have any. So before you make a diagnosis of infection, the first thing you want to ask yourself is, what is the status of the patient when it comes to immunocompromised situation? Is the patient immunocompromised, or is the patient not immunocompromised? What is the host immune status? At this point, the host is not actively immunocompromised, because the last time chemotherapy was done was 2023, I believe. And so now you see a mediastinal mass there, and the patient has dysphagia and odynophagia. So this is likely the relapse of the cancer coming back most likely. So that's probably one of the differential diagnoses. I would not invoke a diagnosis of infection yet in this patient in the absence of other systemic symptoms or anything.
Thank you.
Right. Subsequently, she was started on a chemotherapy regime consisting of rituximab, etoposide, doxorubicin, vincristine, and oral prednisolone, also with cyclophosphamide. However, on the 10th day of chemotherapy, she developed fever with neutropenia. Now, the absolute neutrophil count has fallen down to 0.4. And also, she was oxygen dependent with episodic SOB. She needed 2 liters of oxygen to maintain saturation of 94. Her pulse rate was 98 per minute, blood pressure 110/70, and temperature was recorded as 101 degrees Fahrenheit. Her mentation was normal, and also fasting blood sugar was normal. And renal functions were also normal, but ST-OT and PT levels showed slight increase. Bilirubin was 1.4, albumin 3.2, and she tested negative for hepatitis B, C, and retroviral screening. And with this current situation, she was started on empirical IV antibiotics after collecting appropriate specimens for cultures. This is the X-ray taken on day 10 of chemotherapy. Now we have now, Dr. Anga?
From the first chest X-ray onto the day 10 chest X-ray, what do you want to add from here?
Yes. So now the host is immunocompromised. So what is the immune deficit of the host? Is innate immune deficit, neutropenia. And there's profound neutropenia at this point in time. It's, or at least significant, severe neutropenia, ANC less than 0.5. And here clearly you see in the X-ray, in addition to the mediastinal mass that you can see, and just like my teacher, Dr. Chandra and Marissa said, that X-rays are not ideal in this setting, but nevertheless, you can see peripheral nodular lesions bilaterally in this X-ray. And there's also some haziness on the left side. So that is definitely concerning when you see nodular lesions for invasive fungal infection at this point of time.
We were able to do a HRCT on the same day for this patient. So there is a video, I'll play that.
And add something while the video is played on.
So you can clearly start to see peripheral nodules bilaterally. So when you come to CAT scan, in the past we used to do high resolution CAT scan, but now all CAT scans are pretty much high resolution anyways. So, and it's non-contrast. So you want to remember to do non-contrast CAT scan of the chest. And while you have to think of peripheral nodular lesions, and you can see close to the periphery bilaterally, and they are at least a centimeter or more. And that should invoke a diagnosis of invasive pulmonary aspergillosis. And clearly you can see around the nodules, you've had haziness. That is the necrosis. So that's the halo sign. So this is early, suspicious of early invasive fungal infection. My first thought process will be, okay, should I start thinking about invasive pulmonary aspergillosis in this setting?
So we have another, this is the same thing. Right, we have another photo of the same images. Okay. And as Dr. Ramesh mentioned, the HRCT was reported as having bilateral peribronchovascular consolidations and ground glass opacities, mainly involving the left upper and lower lobes and right upper lobe. So now we move on to our first question for the session. Can we have this question on board?
The audience can join and audience can answer the questions as they appear. Scan the QR code and join the questionnaire. You can see about 54, 56 audience members have joined the questionnaire. Do you need any more time? Shall we start the question?
Question
So,
1.
what further investigation will you request, assuming you are investigating for a fungal pneumonia? You will have 30 seconds. So first answer is serum galactomannan, sputum for culture. Second answer is bile galactomannan or bile for culture. Third answer is serum for mannan and anti-mannan antibodies and blood culture. Fourth answer is serum beta-2 glucan sputum culture. So majority have answered the right answer, about 40. So let me go to Dr. Ramesh. Now, this patient is having, as you said, invasive fungal infection. We have the high risk, high suspicion in the right population of the patient because the patient is having chemotherapy and absolute neutropenia. So, what would you do as the investigation of choice?
Okay. So ideally, in this population, you don't want to mess with them too much in terms of invasive procedures. But having said that, BAL, as long as it's just a wash, it is okay. We just don't want biopsy because remember the patients are thrombocytopenic. So generally in the United States, what we do is we will order biomarkers that the availability of beta-glucan for negativity for the test may be there, but more importantly, a BAL galactomannan and a serum galactomannan will be done, and you look for an optical density of at least 1 or higher at this point in time. So in either one of them, that'll help us. And clearly, you would have sent for culture from that procedure as well. It's very unlikely you get sputum in this population. Very difficult because the patients don't produce much sputum at this point of time. But if they do, then you are able to do get sputum culture directly.
Dr. Namal, in the interest of the trainees, when you take the culture or the samples, how do we proceed with that? What are the samples needs to be taken? What are the precautions that we need to take? How do we transfer the samples to the laboratory?
Yeah, thank you, Ranga. So, as Dr. Ramesh said, the ideal would be the BAL and the BAL galactomannan. So, as this patient is severely thrombocytopenic, we did not usually go ahead with it. If the patient is producing sputum, please by all means get a well coughed up early morning, if possible, sputum sample and send it for fungal culture. Send it as soon as possible because obviously otherwise it will get overgrown by the bacterial colonizers. Send a serum for galactomannan, and when you send it, make sure you send it in a new, not reused, sterile container because we get a lot of false positives in samples which have in containers which have been reused. So please do send a new one in a sterile screw-capped container.
Thank you.
Right. So this patient had some further investigation. We did sputum for fungal culture, and the direct smear showed fungal hyphae suggestive of aspergillosis, and subsequently Aspergillus niger was isolated in culture. But unfortunately, due to technical reasons, we could not do the sensitivity testing for this isolate. Her serum galactomannan came as 1.06, and sputum for bacterial culture had multi-drug resistant coliform isolated. And she also had AFB and gene expert testing for TB, which was negative. Now it's time for the second question.
So, would you consider antifungals? What would you prescribe? IV liposomal amphotericin B, IV voriconazole, IV endulafungin, no need of antifungals. We have 75 responses so far. Majority have answered IV voriconazole, and 16 of them has answered IV liposomal amphotericin B. Right. In the context of isolating Aspergillus niger, so usually what we get is Aspergillus fumigatus or flavors. So it's a very rare fungi. It could very well be a contaminant. What's your take on this?
Yeah, Ranga. So this patient, if you saw the previous slide, you will see we have said Aspergillus niger, and then a repeat culture was taken quite simply because we had the same doubt: is it a contaminant or is it the actual pathogen? The repeat culture did not grow anything. However, given the patient's clinical context, the patient is profoundly neutropenic, the chest X-ray and the HRCT are very suggestive of invasive aspergillosis, and the patient is febrile and having episodic shortness of breath. So we decided we are going to go ahead and treat this patient. As for the choice, I just want to mention that the antifungal sensitivities we could not do because the plate got contaminated. But however, the sensitivities for voriconazole for Aspergillus niger are little less than for, it's actually significantly less than for Aspergillus fumigatus. So that is why, given the patient's condition, we went ahead and started liposomal amphotericin B.
If I could add a couple of things. Generally, what we would have done is as soon as the patient presented with a fever, a CAT scan would have been done, just like this one. And as soon as CAT scan is done, you would have noticed this, and an empiric antifungal would have been initiated right away at that point of time. And there, classically, we would do IV voriconazole. Yes, you're right that the MIC for Aspergillus niger for azoles, triazoles, is slightly on the higher side, but generally, it is acceptable to do that at this point of time. Now that you have, and there are other reasons that you chose to do IV ambisome or equivalent to that, that is perfectly okay.
Thank you.
As Dr. Namal mentioned, the repeat sputum culture did not isolate any pathogens. And considering the condition of the patient, IV liposomal amphotericin B, 3 milligram per kilogram per day, was started on 20th March. And also, she was started on broad-spectrum IV antibiotic according to the sputum AFC results. Despite completing the first chemotherapy cycle, the patient continued to complain of persistent dysphagia and odynophagia. And to make matters even worse, she developed aspiration pneumonia, which necessitated MICU admission. In the MICU, she was managed with IV antibiotics, antifungus, and respiratory supports and other supportive care. 3 weeks later, on 11th of April, the second chemo cycle with rituximab, gemcitabine, dexamethasone, and cisplatin was started. And further week later, she had a repeat HRCT done. So by this time, she has completed 5 weeks of liposomal amphotericin B. Now, this is the repeat HRCT image.
Would you like to comment on, Dr. Ramesh?
So in the repeat HRCT, it looks like there may be either worsening of the original nodules or mostly some newer development of nodules as well at this point of time. And there's a little bit of, some of them do have air in it. So if it is, one thing to remember in invasive fungal infection is early in the course of treatment, there is actually radiologic worsening, and then there is improvement. So that's not uncommon. So we never get worried about it when we see that. But if there are new lesions that were not there before, that is worrisome. So the question is going to be, okay, what is this new lesion going to be in this case? And you're giving a very good drug. So what is the breakthrough infection here at this point of time? So is it because of there is any sort of drug resistance of resistant aspergillus, which less likely because in this setting it was Aspergillus niger. Could this be for ambisome? Could this be an additional added pathogen, fungal or bacterial at this point? Less likely fungal, but you are doing, if it's mucorales, you're doing a little bit lesser dose of ambisome at this point, so you probably would increase the ambisome dose at this point of time. And could this be an additional bacterial infection that is there? Or unusually, the question is, from the mediastinal lymphoma I used, unusual for lymphoma to present in the parenchymal tissue, but could this be something else additionally like that? That should, so you need to start thinking along other differential diagnoses if there are new lesions.
Thank you.
Thank you. So The HRCT was reported as having new cavitations in the right upper lobe nodule, along with diffuse peribronchovascular nodular ground glass opacifications, which suggest of coexistent fungal infection. Then she underwent a sputum AFP and gene expert examination again. This time also they were negative. And to alleviate her symptoms, she was referred to the GI units for esophageal stenting on 25th of April. However, her disease was progressing. She continued to have dysphagia and odynophagia, and the treating oncologist was compelled to change her chemotherapy regime to a ALL-based regime. This is the chemotherapy regime she was started on, right? It consists of rituximab, mesna, cyclophosphamide, dexamethasone, vincristine, doxorubicin, dexamethasone, and again vincristine, dexamethasone on day 11, and from day 12 to 14, dexamethasone alone. So now we move to the third question.
So what will you do now with regards to antifungals? Continue liposomal antipyrrolizine B, convert to IV voriconazole, increase liposomal antipyrrolizine B to 5 mg per kg per day, omit antifungal as the signs and symptoms are due to the disease. Majority have answered increase liposomal amphotericin B to 5 mg per kg per day. Dr. Namal?
So good to see that most of you agree with our clinical decisions. Basically, we increased it because we had no choice. Ideally, in another patient, we would have switched to IV voriconazole because that is the drug of choice. But as you saw, this patient is on a vincristine-based chemotherapy regime, so we are not going to go ahead and add voriconazole because of the risk of neurotoxicity. So the only option we had, as Dr. Ramesh said, to cover the mucorales as well, we decided to increase the dose of liposomal amphotericin B to 5 milligrams per kilogram. However, at the back of our minds, we still had the doubt, is this actually the disease which is progressing? So that is why the fourth option is there. Are you going to omit? But we did not omit given the patient's very precarious condition.
Dr. Ramesh, in this patient now, as a practicing clinician, I would worry about the toxicity, other differential diagnosis, and what are we going to do with the antifungals?
Okay.
Are we really going to increase the dose of antifungal because the patient is deteriorating and the organ functions are crashing? So what's your take on it?
So generally, when things are going downhill like that, you are moving into salvage mode, salvage therapy. So there you can do combination therapy, and we may generally start an ichinocandin. I know it's not available in Sri Lanka, so we may start an ichinocandin along with the liposomal amphotericin B. I totally agree. I would have increased the dose as well at this point of time. From the trainee standpoint or junior faculty, the issue you need to remember about azoles. In case you use azoles, triazoles, particularly voriconazole, has a lot of drug interaction because voriconazole is not only a substrate for the CYP3 mechanism, which is, you want to remember, the CYP 2C19 or 3A4 are the two main ones. There is other CYP2C9 as well. So you want to remember that. But in addition, inducers of because what voriconazole does is by blocking 3A4 inhibiting and stuff like that. So you increase the level of drugs that gets metabolized to that. And vincristine is a classic one. So you will get severe neurotoxicity when you are doing this. And classic other medications that you want to remember as well. There are many in the list you can do. Nowadays, you don't have to remember. If you want, you just look it up online. So any drug that you prescribe, including PPI, for example, you want to double check for drug. Nowadays, there's no excuse. You only have it in your app. So I would always double check every time you prescribe a medication, is there drug interactions at this point of time? So you want to be careful. But we would have gone into salvage mode at this point of time.
Thank you.
As there was no alternative, IV liposomal amphotericin B was continued at a dose of 5 milligram per kilogram per day. But she was doing poorly. She developed fever following chemotherapy. This time, WBC counts has fallen. It was 0.08 with absolute neutrophil count of 0.01. HB and platelet counts were also low. This new development compelled withholding of her chemotherapy treatment. And then she started complaining of right-sided axillary and upper limb pain, together with shortness of breath. The treating clinical team suspected of a DVT or a pulmonary embolism and investigated in that line, but the investigations were negative. And by this time, we had a repeat serum galactomannan done. Now it has come down to 0.33. As you may remember, the previous one was 1.06. And then there was another challenge. So on 26th of May, on the 66th day of liposomal amphotericin therapy, we ran out of liposomal amphotericin. Now, there was no other choice but to start the patient on IV voriconazole. It was started at 6 milligram per kilogram 12-hourly dose on the first day and continued as 4 milligram per kilogram 12-hourly from the second day onwards. Unfortunately, despite all attempts, due to the complications of the disease, the patient succumbed on 31st of May. Dr. Angad?
As we come to the end of the case number 1, what's your take-home message, Dr. Ramesh?
The take-home message when it comes to invasive fungal infection is obviously it's difficult to diagnose. You want to have a high degree of clinical suspicion. And if you suspect, you want to start something very early. Get your, whatever reasonable diagnostic test that you're able to get, try to get that early at this point of time. And despite what you do, you're not able to modify the immune status of this patient. In this case, it's neutropenia. So yes, in US, what we would have done in a rare situation, we may have done granular, say, transfusions and stuff like that. But usually it's not something that is readily available or it's difficult. So there is only so much you can do. In this case, the galactomannan did seem to drop down a little bit, and the patient did get almost 60 days to 8 weeks of therapy. So I'm assuming that the disease from the fungal infection portion probably was okay or reasonable, but it's the other one, the primary disease was worsening. So that's tough.
Dr. Amal, do you want to add anything?
Yeah, just want to mention, like, okay, in this patient, we consider the serum galactomannan as positive because in the clinical context. So sometimes you have to be very careful because sometimes even without radiological signs, some people might send a serum galactomannan or thinking, okay, is this possible, especially for a patient with PUO? So always take it in the clinical context and not as a standalone test, and always repeat your galactomannan to see if you're going in the right direction and if there is a dropping trend in the galactomannan, and do not take it as a standalone test unless in the correct patient population, like maybe the transplant population. Yeah.
Thank you.
Yes. Then we will move to our second case. Now, this time we have an 18-year-old boy. He's a previously healthy schoolboy, and he was diagnosed with BAAL in June 2024. So he was started on chemotherapy with induction starting in August 2024, with the subsequent consolidation phase. So on 5th of November last year, she was admitted for the third block of consolidation phase. He was on cytarabine, etoposide, methotrexate, and pegylated asparaginase, together with oral imitinib, and also with GM-CSF. However, on the 10th day of chemotherapy, he developed fever. It was recorded at 100 degrees Fahrenheit. His pulse rate was 78, blood pressure 110/70. He did not have any skin rashes, lungs were also clear, and there were no abdominal symptoms. He maintained saturation with room air, and his chest X-ray was also unremarkable. By this time, his WBC counts has fallen to 0.55 with absolute neutrophil count of 0.2. HP and platelet were also dropping. With his condition, he was started on empirical IV broad-spectrum antibiotics as per institutional policies after collecting necessary specimens for cultures. Despite being on broad-spectrum antibiotics, his fever was increasing, and by 13th day, he went into septic shock. Now his pulse rate was 112, blood pressure 84/42, lungs had bilateral crepitations, but abdomen was soft with bowel sounds present. He maintained saturation, and his GCS was normal. In addition, WBC count was 0.1 with absolute neutrophil count of 0, HP 7, platelet has further dropped to 15. And his CRP levels has shoot up to 183 grams per deciliter. Serum creatinine remained normal, and SGOT and PT levels were slightly increased. Total bilirubin was 1.08. He also had a blood picture done, which showed nomochromic nomocytic anemia, and there were no blasts seen. As per his management, he was given inotropic support and broad-spectrum antibiotics, and managed as a patient with neutropenic sepsis with lower respiratory tract infection. Further, we had done by this time we have got the results of our septic screening. His blood culture remained negative, and there was a Candida species isolated from his catheter urine sample. His sputum indicated only normal flora, but his nasopharyngeal aspirate for COVID PCR tested positive. Now we come to our next question, the first question for this case.
Would you consider adding antifungals? What would you add and why? And what are the other additional considerations? So first answer is no, I wouldn't add antifungals. Second one is yes, I would add IV amphotericin B. Third one is yes, I would add IV fluconazole. Fourth one is I would add oral fluconazole. Majority have answered the third one, but there's a significant amount of other answers as well. So from this point, now we have a right patient population. Actually, patient is on chemotherapy, patient is having severe neutropenia, and while on empirical antibiotics, patient is still deteriorating. So what is your take on it?
Yeah, so the key here for people to remember is the patient developed shock. very unusual for mold infections like Aspergillus or Mucorales to cause shocky situation. When you're shock, you need to worry about, particularly, and the second key point is you're already colonized in the urine. Yes, the urine is probably just like an indication of colonization, but the fact that there is colonized in the right setting, you would consider this. So invasive yeast infection, in this case Candida, invasive candidiasis, and bloodstream infection from Candida is something that you would strongly suspect at this point of time. So we would have definitely started IV echinocandin in this setting because of the shock situation. We would have done beta-glucan there, but unfortunately it's not available here. So that's what we would do. By my understanding, IV echinocandin is not here, so in Sri Lanka. So I would do very high dose fluconazole at this point of time. And the purpose of high dose fluconazole is Candida glabrata has resistance, but my understanding, knowing your, that's where I think, knowing your microbiology here, I believe here tropicalis may be the most higher one, both in India and here. So if that is the case, this one. But when the patient is shocky, we would always start with a higher dose. Originally, I'm talking before the availability of echinocandins in US, we would have done high dose, 800 milligrams of IV fluconazole, something in that ballpark, is what we would have started, and then downgraded it very quickly.
You want to add anything, Dr. Raman?
Yeah, I just want to cite one of the papers where the sensitivity of the Candida isolates from 2018 to 22 was published by one of my colleagues, Dr. Velagedara. In that, the overall sensitivity for fluconazole was around 92%. So actually, I was quite shocked because I didn't expect it to be high. So given that and the context that we do not have a echinocandin, yes, I agree with you, in a patient with septic shock, we would go high and then come down. So given the context that this patient is already colonized with Candida, and I just want to introduce the term of Candida risk score. So this patient is in septic shock, inotropes, is in an ICU, broad spectrum antibiotics, on having central lines. So all of them are risk factors for having invasive candidiasis and candidemias. So in that context, even when we get colonized culture positive, we will go ahead and start an antifungal.
Thank you.
So, as Dr. Namal mentioned, the patient was started on IV fluconazole at 6 milligram per kilogram per day dose. And the next day, his blood culture signaled positive for yeast. And subsequently, it was identified as a Candida tropicalis species sensitive to fluconazole. And IV fluconazole therapy was continued further until we get 3 repeat cultures negative, right? And I would like to add some further details about this patient. So by this time, the patient did not have blurred vision and there was no onset cardiac murmurs, but he did have right upper chondral tenderness to palpation. And also, he continued to have on-end fevers even after completing fluconazole therapy. Question 5.
So what further investigations management are required at this point? Remove CVP. So the question will appear first and the answers will appear next. Remove CVP if present, 2D echo to exclude endocarditis, eye referral to exclude endophthalmitis, ultrasound scan abdomen to exclude visceral involvement. So responses will come now. So A or B, A, B, C, all are correct, or all of the above. So majority have answers all of the above. So Dr. Amal?
Yeah, so respectfully, I disagree. So in this patient, the absolute necessity is if the patient is not neutropenic, take off the line. But if the patient is neutropenic, in this case, you will have to consider according to the patient's condition, because if the patient is having thrombocytopenia, you would not want to risk taking out a line. And the site of infection may be due to the mucositis rather than the central line. So according to the 2025 guidelines, the absolute mandatory thing is to examine the patient, a very well thorough physical examination to look for metastatic infection. So you would want to look for endocarditis, new onset murmurs, Yeah, so ask the patient if they have a recent onset blurred vision for endophthalmitis or chorioretinitis, and if there is right upper quadrant pain for hepatosplenic involvement. So depending on that, you will proceed. So in this patient, if you remember, he is complaining of right upper quadrant pain. So we would go and ask for an ultrasound abdomen. As for the other ones, you may take it or leave it. I mean, the patient has no plastic, there's no devices, cardiac devices, there's no abnormal valves. So, of course, as far as endocarditis is concerned, since the fever persisted, you might want to do an eye referral if available. But of course, in a neutropenic patient, you will have to wait till the counts have recovered, because otherwise you won't be able to see the lesions. And then within the first week of recovery from neutropenia, to do the eye referral. Yeah. Do you want it?
No, I do agree. I totally agree. Unlike in traditional settings, which non-neutropenic settings, you are quick to remove lines. But in neutropenic settings and stuff like that, you try to preserve lines even in the setting of candidemia, because you know you have to remove the line at some point, but unless you're forced to, you try not to. In this case, you were shocked, so you could go either ways. You may have removed the line at this point. And the rest of the ones is very important. The patient already has right upper quadrant symptoms at this point, so I would focus more on the right upper quadrant along with the physical exam, and then follow up eye exams. Our patients are admitted, we get inpatient hospital consultation, so the eye doctor will come right away, and then they will automatically follow through and keep checking the eyes at this point. And if needed, if there's persistent fevers or if there is persistent blood culture positive, obviously you'll be doing an echocardiogram. You wouldn't do an invasive test like a TEE or a transesophageal echocardiogram, but you will definitely do a surface echocardiogram, transthoracic. So those kind of things. So it's the clinical thing that is important. But the key here is the right upper quadrant pain. So you would want to image it acutely, whether it's an ultrasound or a CT scan. You would want to double check that quickly.
We had that.
Okay.
So the patient had some further investigations. His 2D echocardiography did not show evidence of infective endocarditis, and ultrasound abdomen showed only fatty liver with mild hepatomegaly. And we could not do an eye referral on this patient. With regard to his antifungal therapy, IV fluconazole was converted to oral fluconazole after completing 5 days and continued for total of 14 days from the last negative culture, and it was omitted after that. But still, despite completing the fluconazole therapy, the patient was continuing to have fever, although he was hemodynamically stable. By this time, his WBC counts have picked up to 8.26. However, HP and platelets were still on the low side. On further investigations, he had a repeat nasopharyngeal swab done for influenza and COVID PCR, which came as negative, and serum procalcitonin levels was found to have elevated to 12.3. He also underwent a lumbar puncture examination in which we could not detect any pathology in the CSF. In the bone marrow examination, there was moderate completely hypercellular marrow with less than 1% of blast. And melioidosis antibodies were also found to be negative. Therefore, at this point, he had a second ultrasound abdomen scan done. And at this point, he was on the day 38 following his chemotherapy. In this scan, we found some sinister sign. There were multiple hyperechoic lesions seen in the liver, spleen, and bilateral kidneys, and possibly suggestive of microabscesses. So we have an image here. Dr. Ranga?
So as you said, focus on the patient's symptoms. So we focus on the patient's symptoms and we found hepatosplenic abscesses. What's your take on that?
So this is something very classic. I mean, I have not seen this in 15 years. When I was training, I used to see this because at that time, when I was training a long time ago, we did not use routine use of prophylaxis or yeast prophylaxis or mold prophylaxis at that time because those things were just coming into this one in a high-risk neutropenia. So what do I mean by high-risk neutropenia? Is the neutropenia is prolonged and it's profound. What does prolonged mean? It is at least greater than 7 days or more. Your anticipated duration of neutropenia is prolonged, 7 days or more, or profound is your ANC drops to 0.1 or lower. So it's a very high-risk neutropenia at this point of time. So for this condition, and definitely if your ANC is already less than 0.5, we in the high-risk setting, particularly if there's prolonged neutropenia, we would have given even directly mold prophylaxis nowadays. But let's go back to 15 years ago, you would have done yeast prophylaxis, in this case fluconazole. And the studies were done actually by Chandra, participated in a study published in New England Journal where they did 400 milligrams of fluconazole daily, all the way up to day 100 post. And that's what we did it. And then clearly that reduces yeast-related issue. In this setting, that probably wasn't the case. And now what ends up happening is that the yeast develops bloodstream infection, candida, but as the neutrophil recovers, that's when you see these changes. So now you start to get changes in the liver. So hepatosplenic candidiasis will be there. So now you are supposed to treat it for further length of time. Now the neutrophil has recovered, so you treat it for minimum 2 weeks, up to 8 weeks sometimes. It's difficult to treat hepatosplenic candidiasis, but as I said, I don't see it at all nowadays because of the routine use of prophylaxis, appropriate setting. Not every neutropenia needs prophylaxis, but in the appropriate setting it does. In this case, I would have definitely would have offered prophylaxis.
Dr. Nama, so we have a take-home point from that.
Yeah, so just want to tell about the local protocol. So this patient was ALL. So usually for acute myeloids and for myelodysplasia, MDS patients, we do offer prophylaxis, a mold-active prophylaxis, especially when the disease is still active. For ALL, again, it's a vincristine-based regime, so ideally we have to give, during the induction, we have to give amphotericin B, which, yes, is not being given. We have problems with, as you know, it's not, even as we speak, we do not have it in the country at the moment, very, very unfortunately. But however, after this case, I think we have to rethink our, prophylaxis protocols.
And one other thing I would indicate is understand your, make the hematology oncology specialists your friends, understand the drugs, and ask them the question, how long is the neutropenia anticipated to be there, and how profound do you expect? So, once they tell you, that will tell you how long is the innate immune deficit that's going to be there, and that determines whether what prophylaxis you're going to use, yeast, mold, how long, what it is, and stuff like that. So that is very important because this should not. Shouldn't happen, but I'm not surprised that we still see it in India here and stuff like that. But I've seen it when I was training a long time ago.
Thank you. We have another question for our audience now.
So as the treating clinician, what investigations will you request next. Fungal blood cultures, CCT chest and abdomen pelvis, menin and anti-menin antibodies, serum 1,3 beta D glucan. Majority have answered CCT chest and abdomen. So let me come to Dr. Ramesh. I think previous speaker has answered about menin and anti-menin antibodies. So what would you do at this level?
So it's all those biomarkers, because now it's a localized disease at this point. So you might find that those tests may be negative, including blood cultures at this point of time. So a CT scan would give you the answer. It becomes a clinical diagnosis at that point of time. If you choose to biopsy, if you find lesions there and you choose to biopsy it, and you may find fungal elements in there, but the CT scan should tell you the answer.
You want to add anything?
Yeah, so I just want to add to that. I would actually do the fungal blood cultures, CCT, and if available, the serum BTD glucan as the first choice. Just want to highlight that fungal blood cultures or any blood cultures for visceral candidiasis, it's usually negative, and at best, usually blood cultures are about 50% sensitive. So just because you get it as negative, do not exclude it. So I just want to say that in the absence of beta-D glucan, the next best thing that we have in our country is menin and anti-menin. So do it in combination, not just one, because that will give you a more better clue as to what we are dealing with, which at the moment is hepatosplenic candidiasis.
Thank you.
Yes. At this point, the patient was started on IV fluconazole, again at a dose of 12 milligram per kilogram per day, and his blood was sent for candida menin and anti-menin antibodies. Despite starting on fluconazole, the patient continued to have fever. And after 4 days of IV fluconazole therapy, it was converted to liposomal amphotericin B at a dosage of 3 milligram per kilogram per day because the fever was persisting. And couple of days later, we got the results of candida menin and anti-menin antibodies as positive. And to further support our previous radiological images, the patient underwent a contrast-enhanced CT of chest, abdomen, and pelvis. This time also, there were multiple well-circumscribed hyperattenuating lesions seen in the liver and spleen. However, there was no lymphadenopathy, no perihilar masses was seen, and the esophagus and the gut appeared unremarkable. So, we have to go to the next question now.
How will you proceed with the treatment next? Convert to IV casofungin, add IV voriconazole to IV liposomal amphotericin B, increase IV liposomal amphotericin B to 5 milligram per kilogram per day, or continue same antifungals. So only 23 of them have got the correct answer. Can we see the leaderboard as well? Khan has 35, MS 32. Okay. So, Dr. Ramesh, now coming to the antifungals. So, voriconazole and amphotericin B. What's your choice, and in the context of drug interactions and the toxicity, what are your choices in this context?
Clearly, in this setting, we would have started with an ichnocandin in this hepatosplenic candidiasis. And the important to remember is the patient is stable. Now, patient is stable, the patient only has fever. So don't treat a fever. Don't get worried about the fever at this point. Y count has recovered. As when the Y count has recovered, now it's an inflammatory reaction. So that will take a while. So what we do is much longer duration of therapy at this point of time. But since ichnocandin is not available here, you have to balance risk between azole, triazole versus your amphotericin. It could be amphotericin, obviously you have electrolyte disturbances, more importantly renal toxicity, particularly if you end up giving much longer duration of therapy. So that's something you can do. Whereas voriconazole, you can still do oral voriconazole. That's almost identical to IV because of the bioavailability. So you have that advantage. Obviously you will monitor for liver toxicity with voriconazole at this point of time. Being visceral candidiasis and stuff like that, you will maintain a decent level, this one. But the problem with voriconazole, even it's still not considered cidal, and this is not a resistant candida. This is a very susceptible candida. Tropicalis is almost exquisitely sensitive to fluconazole and stuff like that. So I may have just continued fluconazole for a long time if that is the option. I may not have even gone to any of these things. I would have just maintained it much longer for the patient to recover from it.
Add to that questions. What are you interested in knowing the exact subspecies of Candida in this situation?
Yeah. So the ability to identify a species, Candida albicans and Candida tropicalis are pretty susceptible, and glabrata has this dose dependency. In certain people, it is susceptible, and about 50% of the time, it may not be susceptible. Cruzii tends to have more resistance towards the fluconazole, so that's why you use triazoles to begin with, or some other agent like polyenes. So having that drug susceptibility testing, we do that routinely now for Candida, which I'm sure you guys do it too. So you are able to guide therapy appropriately.
So Dr. Namal, in our context, we don't have caspofungin. Yeah. So what we could do at this situation?
Yeah, if I can just add to what Dr. Ramesh said regarding the species, it's quite important to know because, like say, for Candida parapsilosis, even the populations are different. Like you will find it more in the neonates and the pediatric population, tropicalis, and you might see in the hematological population. If you get a Candida krusei, I know that it's intrinsically resistant to azole, so there is no use giving it. As Dr. Ramesh said, glabrata is dose dependent, so you might give it a high dose, like 12 milligrams per kilogram. So coming back to your question, echinocandin, so if echinocandins were available, like caspofungin or anidulafungin, that would have been the drug of choice. I just want to highlight that drug penetration, it depends on the organ. Like, for example, if an echinocandin will not be the drug of choice if you're dealing with renal focus, because in that case, you will either go for an azole or amphotericin B. But, yeah.
To add to that, like echinocandin, our biggest failure echinocandin is pleural space, for example, where it wouldn't penetrate that well. It wouldn't penetrate that well. And so obviously eye is even difficult, so you may need intravitreal injections. In addition, if you find endophthalmitis at this point. So you need to understand where your drug acts. Are you able to deliver to the target correctly as you choose your drugs?
Right. So, considering the patient's condition, IV voriconazole was added to his treatment. And in the meantime, the HRCT done showed bilateral small pulmonary nodules. And we had another problem after 4 days after starting IV voriconazole therapy. The patient started complaining of blurred vision, dizziness, and blackouts. His pulse rate was found to be 50 per minute, and blood pressure was 100/70. The patient was referred to the physician, and he had done an ECG, which shows heart rate of 52 per minute, and there were features suggestive of heart block. Now we come to our next question.
The last question, what course of action will you take with regard to antifungals? Stop IV voriconazole, convert to oral voriconazole, convert to IV fluconazole, continue IV voriconazole. So stop IV voriconazole. Dr. Namal, in the interest of time,
So IV voriconazole is known to cause QT prolongation, torsades points, the blurred vision, perception of color vision. So if, of course, those are reversible. So if you must continue, you can. If it is distressing to the patient, you will have to take it off because most of them, with prolonged therapy, they subside. But here the patient is already on amphotericin B, so we would have omitted the voriconazole, which we did.
Dr. Ramesh, do you want to add anything?
Yeah. See, in this case, it was heart block. It was not QTC prolongation necessarily, because that QTC causes torsade. Typically, heart blocks are not necessarily associated with voriconazole. But if there's any cardiac suspicion you're worried about and stuff like that, you want to switch your antifungals, that's perfectly okay. So.
Thank you.
Right. So that brings us to the end of our case. Finally, after 2 weeks of IV liposomal therapy, the patient's fever subsided. And he is planned to have a repeat CECT of chest, abdomen, and pelvis in about 1 month's time.
In the interest of time, would you like to add some take-home point
Yes.
for the benefit of the trainees?
Yeah, so a key element is try to understand what your immune deficit is, in this case, innate immune deficit in this population, and how long is the deficit going to last. And that helps you determine whether you want to give prophylaxis. And that also guides you what to suspect when it comes to invasive fungal infection. In this particular setting, for treatment of hepatosplenic candidiasis, you need a little bit longer duration, and you definitely want to follow up with the imaging to make sure things are improved.
Just want to add to choose your antifungals carefully, depending on the toxicity, depending on the site of infection, depending on how long you want to treat, how sick the patient is. So, I mean, the mycologist is always ready to help you. So, choose your antifungals wisely and judiciously.
Thank you. So, as we run out of time, I would allow one question from the audience, if there's any. In the absence of any questions, I wound up the session. Thank you, Dr. Ramesh. Thank you, Dr. Namal. And thank you, Dr. Chetana.
Thank you.
I thank all our speakers and everyone involved with this session and for taking us through such an intellectual journey. I cordially invite our chairpersons of the session, Dr. Ratnayaka and Dr. Jayasekara, onto the stage to present the certificates of appreciation. I welcome our distinguished speakers to receive their certificates. Dr. Mayur Ramesh, and Dr. Namal Jayawardena. And also Dr. Ranga Gunasekara, our moderator for the session. I also invite our case presenter, Dr. Chetana Premasiri, Senior Registrar in Mycology, to receive your certificate. Thank you, Dr. Ratnayaka and Dr. Jayasekara. Before we move forward to the next symposium, now it's time for a short tea break. Refreshments will be served at the adjoining hall, and we will resume the conference at 11 a.m. Again, I remind you, ladies and gentlemen, do give a visit to the stalls of our industry partners, which is installed at the adjoining hall. Thank you.